Just 3, 2, 1. Yes, sir, start.
So teaching class of yes. So welcome once again. Welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today we have a presentation on post-obstructive diuresis and retroperitoneal fibrosis and retrocaval ureter. So this will be presented by our resident Dr. Mayank and moderated by Dr. Somendra. So request Dr. Mayank to go ahead with the presentation. Mayank, please go ahead.
Good morning, respected faculties, my seniors and my colleagues. Today's topic of seminar is post-obstructive diuresis, retroperitoneal fibrosis, and retrocaval ureter. I am presenting it under the guidance of Dr. Somendra Bansal, sir. Starting with the post-obstructive diuresis. Starting with the definition, post-obstructive diuresis is defined as dramatic increase in urine output after the release of obstruction, or more precisely, the urine output greater than 200 ml per hour or more than 3 liters per day. Like accumulation of total body water, body abilities. It is more significant in case of bilateral ureteral obstruction or obstruction of a solitary kidney. If diuresis persists beyond the euvolemic state, a pathological concentrating defect is suspected. Pathological concentrating defect or salt was wasting diuresis is suspected if diuresis persists beyond the euvolemic state. In case of excess free water loss, plasma osmolality will rise, whereas the urine osmolality remains low. Patient with intact thirst mechanism or having free access to water can compensate for this defect. Patient with altered sensorium or in whom oral replacement is not an option because of a mental status, supplementation with IV fluids with hypotonic saline is recommended. Mostly literature recommends the replacement of half of the urine output at 2 hourly intervals. Contraindication to the IV fluid replacement is the CHF and hypertensive crisis. Pathological post-obstructive diuresis secondary to salt diuresis. It is mainly due to the dehydration and it is mainly due to the natriuresis, and dehydration and electrolyte imbalance are common. Urine osmolality is slightly higher than that of plasma. Careful hemodynamic monitoring and frequent monitoring of both serum electrolyte and RFT is required. In these cases, sodium and volume replacement should match with urine output in 1:1, and it is corrected with 0.9% NS or 3% sodium if the deficit is pronounced. Hypokalemia and hypomagnesia are also very common with this type of diuresis, and it requires IV correction. The complications associated with post-obstructive diuresis are volume depletion, hyponatremia, hypokalemia, hypomagnesia, which require the correction, metabolic acidosis, and shock. The recent experimental modulation in post-obstructive diuresis, it has been seen that ureteral obstruction induces the expression of COX-2 in the collecting ducts and downregulation of aquaporin 2. Hence, the COX-2 inhibitor prevented the downregulation of aquaporin 2 in rats and significantly diminished the post-obstructive diuresis. Coming to the retrocaval ureter, it is also known as the circumcaval or pre-ureteric vena. Its incidence is 1 in every 1,500 individual of a population. It is slightly more predominant in male. It is although it is a congenital anomaly, it present in the 3rd or 4th decade. This diagram shows the normal development of inferior vena cava. The definitive IVC developed from the plexus of fetal vein. The retropentate, there are central veins. The posterior This is an operative video of patient of retrocaval ureter operated in our institute by robotic method. The key steps involve mobilization of colon, identification of ureter, and excision of proximal and distal end. After excision of ureter, both proximal and distal end are spatulated and anastomosis over DJ strand. The retrocaval segment may be left or excised as it may be aperistaltic. Coming to the retroperitoneal fibrosis. Its incidence is 1 in 2 lakh of individual of a population. It is slightly predominant with a ratio of 2 to 3:1.
एक से बुला के लाओ उसको फोन करो
अब से आ रहा हूँ
अब आ रहा है जैसे आवाज देखो
Coming to the retroperitoneal fibrosis, its incidence is 1 in every 2 lakh of individual of population. This condition is slightly predominant in male with ratio of 2 to 3:1. It is a disease of middle age with peak incidences between 40 to 60 years. Coming to the presentation, most of the patient present with the pain in the lower back and flank. Other symptoms associated with this condition are weight loss, anorexia, fever, hypertension, or oliguria. In the disease process, there is a fibrotic mass which usually center around the distal aorta at the level of L4 to L5. It may compress the IVC and causes the lower limb edema. It may extend proximally to the renal vein, causing the hypertension and hematuria. The duration of symptom before diagnosis is usually made is around 4 to 6 months. Coming to the types of retroperitoneal fibrosis, approximately 70% cases are of idiopathic type, which include the periaortitis, which is a large vessel vasculitis. In this, the steroid is the most common inciting inflammatory agent, which is a oxidized compound of lipid and protein found in atherosclerotic plaque. Other causes include like drug use of methotrexate, beta blocker, phenacetin, and methyl-dopa in various conditions. Autoimmune disorder associated with RPF are rheumatoid arthritis, SLE, autoimmune thyroiditis. Most common malignancy associated with RPF is lymphoma. Other malignancies are associated are multiple myeloma, carcinoid, and sarcoma. Radiotherapy for retroperitoneal malignancy can also cause the retroperitoneal fibrosis. Evaluation. Generally, the patient of retroperitoneal fibrosis shows the non-specific symptoms. On laboratory evaluation, there is elevated ESR, CRP in 1/2 to 2/3 of cases. On CT urography, there is a medial deviation of proximal and mid ureter. On MRI, there is a diffusely low signal on T1 and high signal intensity on active disease on T2. Provides a measure of therapeutic efficacy of the treatment. In case of diagnostic dilemma, the representative biopsy should be taken percutaneously or at the time of ureterolysis surgery. This is a CT urogram. This is CT urogram showing the medialization of both ureter and causing proximal upstream dilatation. This is known as maiden waist appearance. Management. The management of retroperitoneal fibrosis depends on the clinical status of the patient Patient having deranged RFT or having low urinary output should be emergently decompressed with either PCN or degestant. Degestant has advantage of internal drainage as well as provide us an opportunity of performing an RGP simultaneously. After the relieving of obstruction, patient should be monitored for post-obstructive diuresis. RFT should be monitored and appropriate fluid replacement should be given. And biopsy at the time of surgery should be taken to rule out any malignancy. Medical management. Steroids is the mainstay of treatment of RPF. Dose and duration vary considerably in various literature. However, the most regime start the doses with 60 mg daily to taper to 5 mg daily. With the starting of steroid therapy, there is a resolution of pain and constitutional symptoms, and there is rapid decrease of ESR and diuresis. Patient having inflammation, like having increased ESR, CRP, leukocytosis, are more likely to respond to the steroid therapy. Immunosuppressive drugs are reserved in patient in whom steroid therapy fails, as the relapse is as higher as 50% during the tapering of steroids. Surgical management. In surgical management of RPF, bilateral ureterolysis is recommended. We have to physically separate the newly freed ureter from the fibrotic tissue, and we have to create a physical barrier between the fibrotic tissue and the ureter, so the ureter does not fall into the retroperitoneum and again becoming entrapped again. So we have to one technique is to retract the ureter laterally after release and close the parietal peritoneum over the fibrotic bed. Omental wrapping can also be done after intraperitonealization of the ureter. It provides the protection against the extension compression as well as it provides the vascularity to the potentially ischemic ureter. Renal autotransplant should be considered in patient having extensive periureteral fibrosis.
Thank you, Mayank. Nimeshji, can you hear me? Can you hear me? निमेश
जी सर।
आवाज आ रही है?
Yes sir, yes sir.
Okay, so if there is any problem, just let me know, right? So I think these three topics are important. First of all, post-obstructive diuresis, probably we have not been discussing it quite often, but this is an important topic. Post-op diuresis, as we all know, the definition is that when there is a diuresis after decompression of obstruction, which could be a bladder outlet obstruction or a ureteric obstruction, when the urine output is more than 200 ml per hour for 2 consecutive hours, or more than 3 liters in 24 hours, right? So this is the clinical diagnosis where the response is a physiological response. Because of the obstruction, there is overload, fluid overload, and solutes which collect after the obstruction, they would tend to come out by a diuretic phase. So this is a physiological response usually, which extends for usually within 24 hours. But in some of these patients, this physiological response could be pathological. If it extends for more than 24 hours, which can extend up to 48 hours or even longer. So in that case, it can become even lethal or fatal. That is why this is so important to understand the diagnosis of post-obstructive diuresis, particularly in elderly patients who have certain risk factors, like if there is a renal compromise, renal insufficiency, or congestive heart failure, or the patient is in fluid overload, right? All these are risk factors where there is an increased chance of developing a pathological post-obstructive diuresis. Here, the patient may go into dehydration, hypovolemia, shock even, and the patient may die even if you do not manage the patient properly, his fluids and electrolytes. So these patients, particularly, you have to be very careful in patients who come with chronic urinary retention, right? So typically it occurs in patients with chronic urinary retention where the after decompression you find more than 1.5 liters of urine coming out. Okay? And chronic urinary retention could be a high pressure or low pressure. High pressure, when it starts with, is kind of a prognostically bad because it causes damage to the upper tracts also. So once you have decompressed the bladder, you have to monitor the fluid and electrolytes, monitor the weight of the patient, and do some investigations like the fluid, serum electrolytes, sodium, potassium, and then urea, creatinine, even magnesium, phosphorus, and these are important. And as he said, in the management part, usually you would give 50 to 75% of the diuresis that is occurring within the last 2 hours, because you have to always keep it in a negative balance. Otherwise, if you keep it more or same or even more, then it can aggravate and can cause even pathological diuresis, which would be more harmful to the patient. So always remember, and then you have to have a differential diagnosis, because this is a case of polyuria, right, which is happening in particularly after decompression of obstruction. So you must know the other causes of polyuria, which could be diabetes insipidus, which could be drug-induced causes, giving diuretics to the patient, and then increased IV fluids intake, and all this. There are a lot of causes of polyuria, which you must remember while diagnosing this post-obstructive diuresis. So I think this was about post-obstructive diuresis, which you must be very careful, because all these patients who have a risk of pathological diuresis should be hospitalized for at least 24 to 48 hours to monitor them. Otherwise, it could be really lethal for patient. Second topic was retrocaval ureter. Right? Retrocaval ureter is, as we all know, is a congenital abnormality, and the better term is pre-caval ureter. Because the main embryological aberrance is the IVC and not the ureter. So the IV, there's abnormality of the development of IVC, which results in this abnormality, and that is why the better term is a pre-caval ureter in the third or fourth decade because of the hydronephrine, etc. As we in any way. Are you getting the voice now? Yes. So we were at retrocaval ureter, right? So usually these patients would present in third and fourth decade, and male predominance is there. Usually 1 in 1,500 patients may have this kind of a pathology. And as he said, this type 1 variety is 90% the typical fish hook deformity, S deformity, and type 2 is a kind of a sickle deformity, which doesn't have usually hydronephrosis. And this type 1 usually presents with typical hydronephrosis. And the obstructive segment is usually the segment which is lying around the IVC, which could be either a fibrosed ureter, it could be a dynamic segment, or of the kink of the ureter itself may cause this obstruction. So the treatment, again, if there is a gross hydronephrosis and obstruction, you need to treat it surgically. All the 3 options are available: open, laparoscopic, and robotic, right? And the results are very good. The third topic was retroperitoneal fibrosis, right? So retroperitoneal fibrosis, as we all know, is also known as Ormond's disease. Again, it could be 2 types. One is a primary retroperitoneal fibrosis, or it can be called idiopathic cause. 70% of these are due to idiopathic cause and 30% secondary causes. Again, this patients usually present in 4th to 6th decade, and male predominance is there, about 2 to 3:1, right? Idiopathic, as I said, the etiologics because of a polymer of atherosclerotic plaque which develops around the vessels, and this causes a chronic inflammatory response and results in fibrosis. Usually, the spectrum will also include various large vasculitis and periaortitis, etc. Right, and then the treatment part, as I said, the first is the medical management. We start with steroids, usually 1 milligram per kg per day. So if it is a 60 kg patient, 60 milligrams start, continue with for 4 to 6 weeks, and then taper the dose to 5 milligram per day. So the treatment can continue for 2 to 3 years. So if the patient doesn't have a response or there is a relapse, then immunosuppressive drugs can be used. And those drugs you all know, azathioprine, cyclosporine, cyclophosphamide, etc. And other things is the secondary causes. Secondary causes could be either due to malignancy, which could be lymphoma, sarcoma, or as I said, carcinoid. It could be infectious also. Sometimes granulomatosis or even toxoplasmosis, actinomycosis can cause this kind of retroperitoneal fibrosis. Certain drugs can cause, like methysergide, argot alkaloids, beta blockers. These are some of the drugs which can induce retroperitoneal fibrosis. And then even radiotherapy, radiation can induce retroperitoneal fibrosis. And even if you do a retroperitoneal surgery, there may be a post-surgical retroperitoneal fibrosis. So all these could be causes for secondary retroperitoneal fibrosis. And again, the treatment is treatment such if there is dilatation, and many of these patients might go into uremia and raised creatinine values, and you have to decompress the kidneys either by DJ stenting or by PCA, percutaneous nephrostomy. And once you stabilize the patient, to do a ureterolysis on both the sides and try to intraperitoneal ureter with an omentum. So you don't never go behind the peritoneum. Right? So the parietal peritoneum, only to lateralize the ureter, you can attach it with the parietal peritoneum. But basically, and wrap it with omentum to prevent it from fibrosis and to vascularize the ureter. Because after ureterolysis, there may be some devascularization of the ureter. So it is important to do an omental wrapping in these patients. 3 topics are important from your examination point of view also, and from clinical practice also. So any question from anybody? If anybody has any question, please let me know. I can see Dr. Dogra also joining us. Dr. Dogra, can you unmute yourself and
Yeah, good morning.
hello, yes.
Good morning.
Good morning,
Can you
sir.
hear me?
Good morning. Very,
Very.
yes, sir.
I
Warm
thought I should also
yeah.
refresh my what is about this topic. Very nice discussion I was listening to, and you have given a very precisely summarize what is this pathology and how one should manage this. Is
Right,
really.
sir. So would you like to add something to it?
I would like to add regarding this erythroperitoneal fibrosis. Sometimes the disease is very extensive, so much so that the disease is creeping into the wall of the ureter. And the ureter in the process, they're very thin and atretic. And if you do ureterolysis in this case, as you already mentioned, be careful. There is chance of ureteral necrosis. I have seen one patient who developed bilateral ureteral necrosis following this extensive devascularization, and the patient was then on bilateral nephrostomy. At that time, I'm talking. Well, now you can mend this later on by whatever reconstructive procedure you have to put a bowel or whatever it is. But one has to be careful that one should not just believe that mobilize the ureter and everything will be good. There are chances if very extensive disease. Sometimes if the double stand doesn't go, and if it goes, it doesn't drain. That is another issue. So you have to ultimately do a PCN to improve the renal function. This is just, I want to add this thing. Thank you.
Right. So you're very correct, sir. Because when doing ureterolysis, you definitely can cause ischemia or sometimes even transect the ureter at times, damage the ureter. I think when we have robotic and laparoscopic, probably this helps in better dissection of the ureterolysis ureters and doing a proper omental wrapping and intraperitonealization.
Yes,
agree with me, sir? Yeah. Yes.
A word of caution. If it is extending down below the iliac vessel, be careful. I have seen injury to the iliac vessel, which ultimately ended in loss of the patient due to bleeding, being done by robotic.
Right.
So one should not take it everything is fine, is wonderful or something. One has to be very careful and decide on the merits and on your personal experience what you can do, and also the other support available, especially the vascular surgeon. If you injure a vessel in this area, so especially the vein is very dangerous. Arterial injury is okay, but if you injure the vein, then it's very dangerous. So one should have some arrangement with the vascular surgeon if you are attempting a dissection in this area. This is, I'm just giving you my personal viewpoint, and also I had experience. This is not something I'm telling you on the virtual. This is not a virtual. This is real stories.
Right. No, very, you are very right, sir. You have brought out a very right point that we have to be very careful while dissecting the ureter, and when you're going down, the vessels are there. You have to be very careful about that. And I would like to say to the residents that, see, this, as I said, this disease usually starts from the atherosclerotic plaque around the vessels. So the periaortitis, even the veins and arteries can be engulfed by this fibrosis. So you have to be very careful in these patients, and sometimes these patients would present with features of compression of the artery or vein. Like if it is IVC, which is engulfed, then the patient may present with the edema, bilateral edema, and swelling of the feet and all that. And if there is a compression of the common iliac artery or the vessels, there may be even claudication in the legs. So all these symptoms, again, are very important when you diagnose retroperitoneal fibrosis. So, yes, yes.
Yes. Sometimes the younger people, they are very aggressive and enthusiastic. There should not be any attempt to excise the plaque. That is another mistake. You have to release the ureter only.
Yes, that's
true.
It
is to release the ureter, not to excise the plaque. If you end up in that, then you create a lot of complications. You are around the great vessel, then the chance of getting those vessels all the more. Okay.
No, that's true. I'm saying that the pathology is like this. So you have to be very careful. And
Right.
your basic aim is to remove the, do a ureterolysis.
Release the ureter. It has
That's
to be just these
right.
ureter are the hostage. They are like a hostage by this phenomenon.
Right.
You have to
Yeah.
release the hostage. Don't try to bombard that.
Yeah,
The
right.
culprit.
So
Okay.
as now the Israel and Hamas are doing to release the hostages,
Yes.
yes, you need to release this ureter and not do anything else, right?
Yes.
Yeah,
Yes.
right. Yes.
Very nice. Nice,
Yeah.
Shivam.
Thank you, sir. Thank you very much for your expert comments, sir. Anybody else, if there is, who has joined us uh, on this Zoom, they are most welcome to. One thing I want is, we always think this is a physiological phenomenon, so we do not take it seriously. So you have to be very careful. Some of these patients, though it may be uncommon or rare, they may have a pathological diuresis, and the patient, we may lose patients because of this. So be very careful in elderly patients coming with chronic urinary retention. While you're decompressing the bladder, you need to monitor these patients for fluid and electrolytes, and at least for 48 hours. And after that, if it's fine, then probably he may be sent home. So always admit these patients for monitoring the patients. That is, I think, is very important in these patients. Anything else? Any query from anybody? So thank you, Somendra. You want to say something? So, Doctor, I would request Dr. Somendra, who was the moderator today, to wrap up the session and give his final remarks. Somendra, please.
Thank you, Shivam sir, for nicely briefing the topic, and for Dogra sir for the good discussion. I want to add one point in the retropetal fibrosis, that IgG4 disease can also present as the retropetal fibrosis. We have seen 4 to 5 cases of the IgG4 disease, in which 2 cases there is retropetal fibrosis, and 1 case present with the renal hilar tumor, and 1 case present the tumor of the kidney. So be cautious, and we should be kept in mind the IgG4 disease in case of the Reinat who joined us with the seminar topic. Thank you.
Thank you, Somendra, to bringing out a very important point. So all of you must be very aware of a particular entity called IgG4 related diseases. IgG4 related diseases, like it appears like a tumor which is actually an inflammatory mass, which results from this IgG4 containing plasma cells, which are responsible for this inflammatory tumefaction in many organs. So many of these organs may actually have a tumor-like appearance because of this IgG4 related diseases. And this is a very important topic, I think. And there is again a controversy that whether RPF is actually could be a IgG4 related disease itself. So, any comment, Dr. Dogra, on this IgG4 related disease?
Yeah, usually some people call it this like a pre-malignant disease, but I have seen 2 patients, very large tumor in the pelvis, and only by this percutaneous biopsy, this diagnosis was given. At that time, we didn't have this markers for the tumor or staining facility. So it was labeled as an inflammatory tumor, inflammatory benign tumor. But it was not possible to size that mass, and the patient developed bilateral hydroureter necrosis and azotemia. So he was managed by bilateral PCN. Double jet stenting was not possible. Later on, what happened to that patient, I have no knowledge. But yes, this disease, one should be aware of it. It can be aggressive. It's like a cancer. Although they label it as benign, but it's like a cancer. Yeah.
Right. So many of these conditions like RPF, even XGP, and all those fibrotic conditions may actually be sometimes IgG4 related diseases. We don't know. Then you should also be aware of a condition in the bladder that we find malakoplakia, which is again a chronic inflammatory condition. So again, all these inflammatory chronic conditions, you have to be aware of. Thank you again. Thank you, Dr. Somendra, Dr. Mayank for presenting, and all the residents and faculty members who joined us today. And thanks all for those who joined us today on YouTube and Zoom. Thank you, Dr. Dogra, once again. Thank you for your expert comments, and have a good day. Thank you very much.